To be honest, if you look at the guidelines, the follow-up schedule is not really evidence-based. So for high-risk tumors, we know that it's important to follow up because they have a chance of a rapid recurrence of the tumor, which should be treated. And they even have a quite high chance of some dozen % to have progression to muscle-invasive tumor. That's a totally different story. For intermediate and low-risk tumors, it might be much less important than we think, because the chance that patients are harmed by those tumors is really quite low. And for example, in some of those patients I do active surveillance, so I see the tumor but I don't take it out because that's an additional operation. These are older patients. So surveillance in high risk is very important. In low and intermediate risk, there might be a question how important it is. Let's say originally follow-up was cystoscopy and cytology. In the last decade, cytology already was skipped in low and intermediate risk tumors because it's not very helpful. So then it is cystoscopy. And what I currently do is do cystoscopy, sometimes cytology, but also biomarker, a biomarker. So we alternate cystoscopy with a biomarker, meaning that half of the time the patient doesn't have to come, he doesn't get an invasive procedure, the urologist has time to do something different. Maybe it is even more sensitive than our eye to see the tumor, to exclude the tumor, because those markers are very good. They have a negative predictive value of almost 100%. So if the test is negative, the chance that there is a tumor is very, very low. And that's why I started alternating that with cystoscopy, and patients love it.